Thank you guys for having me here today. Special shout out to Dr. J and Dr. Galea for taking part in this research and really helping me kind of see this through in a new avenue of things that I'm doing. I am an assistant professor in the School of Medicine and a trauma surgeon over at Boston Medical Center. We are switching lanes here a little bit out of prevention, a little bit into those who have already been shot, keeping them alive. So this particular study is looking at time to care specifically to hospital care. We know from study in other cities, other states, that the time that it takes and the distance that you have to overcome to get from a shooting scene to a hospital is associated with death. It's associated with death in general after trauma, but shootings in particular tend to be more deadly. And so there's a stronger link there historically. A couple knowledge gaps that we have. One, we don't know if time to care, definitive care, is associated with survival or death in Boston with our unique EMS systems, unique clustering of hospitals, traffic patterns, road conditions, et cetera. And secondarily, and of particular interest, mediated by structural racism, redlining, et cetera, in the city, it's unknown if there is equity in that temporal access to care. Of note in this, since it's not necessarily intuitive, small differences in time to care and time to definitive intervention are important because the longer that you're bleeding, the closer you get to irreversible shock. And by that point, there's not a whole lot we can do to you by the time you get to the hospital. Furthermore, ambulance-based interventions don't have any benefit in hemorrhagic shock in the absence of whole blood or an appropriately applied tourniquet, which is uncommon. So this study, rather uniquely, is actually in partnership with the Boston Police Department, who provided this data, a little bit uncharacteristically, I suppose, but that data included victim demographics, as well as, importantly, outcomes, locations, and type of shooting, meaning multi-victim, single victim. We also obtained data from the American College of Surgeons, from the US Census, from the Shapefiles database, from Boston EMS, and then we used geospatial coding to put all of these things on top of a census map of Boston. We used a network analysis using ArcGIS. Another shout out to Dr. Lane for making me just dangerous enough with ARC to get this done. And combined all that with historical traffic patterns, road conditions, et cetera, to estimate both the nearest trauma center to each shooting victim and the nearest EMS station to each shooting victim, and then calculate the estimated driving times from the EMS station to the shooting scene and from the shooting scene to the hospital. We then used a univariate regression to evaluate this, assessed for spatial autocorrelation, utilizing the global Moran test for the residuals, found that there was some, corrected that with some spatial weights, and did a multivariable analysis. This is the part that everybody wants to see. So we got about 4,500 shootings over the time period here. These are only adult shootings. Overall, they're about 80% Black, non-Hispanic, 8% Black Hispanic, 11% white Hispanic, and 3.5% white non-Hispanic. In our multivariable modeling, accounting for spatial autocorrelation, you can see the map there. There's an association of time to care with an adjusted odd ratio increase of 1.024, that's per minute, as well as an association with victim age at 1.020 per year. So age being protective there. These maps, the colors correlate to the estimated time to care. So green being the shortest adjusted time, and then all the way down to that kind of like purplish color at the bottom. The black dots on that are non-fatal shootings, the white dots are fatal shootings, and the blue crosses are trauma centers. So as you can see, the trauma centers are all clustered very centrally adjacent to one another. The trauma center of note that is closest to all of these shootings is Boston Medical Center. So looking at equity in the temporal access to care, it is not. So there is a difference for each race. Specifically, Black non-Hispanic shooting victims had the longest time to hospital-based care, followed by Black Hispanic, then white Hispanic, and finally white Hispanic victims, white non-Hispanic victims. Overall, there was no mortality difference. These maps include the same color scheme that you can see there. On top of that is a heat map for the density of shootings by race and ethnicity. And the black dot that you can see on top of that is the median location for shootings for each race and ethnicity. So conclusions from this, we have trauma deserts, or areas that have unequal access to care in this city. You can see that pretty clearly just by looking at a map of the city. If we can't bring the hospital to the patients and ambulance-based care doesn't help, then maybe we can get them to the hospital faster, specifically looking at other methodologies. Notably, temporal access to care was not equal by races, but the mortality was not different. That may be due to a difference in demographics such as age, which may have been predictive, with non-white victims being generally younger. We're also missing injury data in this. We did, however, do a counterfactual analysis after our estimations, found that a small number, about 35 non-white victims, would have survived with superimposed white transport times over the study period, which is not insignificant out of about 750 deaths. So future directions, as I mentioned, other means of transport, get that injury and intervention data, and see what the community thinks about it. Thanks.